Now we're going to look at control of urine and reflexes related to this. So hydrostatic pressure here is what causes filtration of the glomerular capillary. The sum of all of these forces is what we call the net filtration pressure, okay? Net filtration pressure here. Glomerular net filtration is normally positive. The glomerular filtration rate here is going to be directly proportional to the net filtration pressure. So whatever affects glomerular hydrostatic pressure, colloid osmotic pressure, or hydrostatic pressure of the glomerular capsule will also affect filtration. The glomerular filtration rate, or GFR, is the most common index or measurement of kidney function. So a change in any of these pressures listed up here, these are going to also affect net filtration and the GFR. So how do we control this filtration rate? Well, we do this through autoregulation. Autoregulation normally controls the rate of GFR. It can, however, be overridden. Basically what it is an attempt to keep GFR constant. So certain conditions can override that, including when your glomerular filtration increases. All right. So we have three mechanisms or three things here that are responsible for keeping it constant. Autoregulation, sympathetic activity that can decrease GFR by causing the afferent arterioles to vasoconstrict, all right? And then we have the renin-angiotensin system, which you've heard me talk about. Sometimes I say renin-aldosterone angiotensin system, okay? So GFR can increase if bodily fluids are in excess and decrease when bodily fluid is conserved. We also have the atrial natriuretic peptide, ANP, which affects sodium, which can cause increases in the sodium excretion. Okay, sodium excretion. Remember, where salt goes, water goes. So where sodium goes, water will follow. Here we can see this renin-angiotensin system. Renin is going to be secreted from the sympathetic nerve stimulation. We have baroreceptors that can sense if our blood pressure drops, or macula densa can sense decreases in sodium, potassium, or chloride ions in the ascending limb of the loop of Henle. Renin is going to then combine with angiotensin to form angiotensin 1. And then we have angiotensin converting enzyme, which we can call ACE, that's going to convert this to angiotensin 2. So this helps regulate sodium and water balance and blood pressure by vasoconstriction of those afferent and efferent arterioles. It can also cause secretion of aldosterone to stimulate sodium reabsorption and antidiuretic hormone, or ADH, secretion, which can cause retention of water. ANP as well, atrial natriuretic peptide, can stimulate the sodium excretion. So substances move from the renal tubules to the interstitial fluid and then diffuse into the peritubular capillaries. An adaptation of the epithelial cells of the proximal convoluted tubule for reabsorption is microscopic projections called microvilli. So most tubular reabsorption, about 70%, occurs in the proximal convoluted tubule, all right, and that is lined with the microvilli. Tubular reabsorption here occurs via different types of transport. We have active transport, osmosis, and endocytosis. Active transport, it requires energy to be used and carrier proteins, and so this is going to be a bit limited here. Then we have an active transport mechanism. We have renal plasma threshold, and that is reached when there is more transported substance in the plasma than we can move. And that's going to be things like glucose, amino acids, ascorbic acid, uric acid, different ions here. And so osmosis, of course, is going to be the movement of water via diffusion, but it's osmosis when we talk about water. And then endocytosis is how we're going to get small proteins in. And in this diagram here, you can kind of see where these different substances are going to enter or leave the nephron here, okay? So water reabsorption occurs passively via osmosis and is closely associated with the active reabsorption of sodium ions. Remember, if you eat something salty, what do you immediately want? You want water, right? So water follows salt. As ions are reabsorbed in the proximal convoluted tubule here, water is going to follow via osmosis. And so here you can see sodium is going in. All right, and so water's going to follow via osmosis, resulting in an isotonic filtrate. Iso means the same, so a similar filtrate inside and out. All right, and so you can see sodium is going in here, and then here's water also going in. So small changes in the tubular reabsorption of sodium and water can actually result in large changes in the urinary excretion of these particular things. So tubular secretion is going to move things from the plasma, all right, from the plasma here. And so we've got blood flowing. So it's going to remove things from the plasma of the paratubular capillaries into the fluid of the renal tubules, all right? So it's going to go into the fluid of the renal tubules. And this is through active transport. And then we will also see secretion of things like drugs and different ions, hydrogen ions as well, which is very important for maintenance of the pH of different bodily fluids. So aldosterone and also ANP from the adrenal cortex cause sodium ions to be conserved, as well as potassium ions to be secreted. And so the ability of our kidneys in order to maintain homeostasis is dependent partially on their ability to be able to concentrate urine by pulling in large volumes of water. So the distal convoluted tubule and the collecting duct, these guys are impermeable to water. They don't take water in, so water is excreted as dilute urine here. The concentration of potassium is going to relatively be a bit higher in the urine than plasma or glomerular filtrate. If we have ADH, antidiuretic hormone, then these segments are going to then be changed to where they are permeable, and it allows water to be reabsorbed via osmosis, okay? And that's going to be by changing the tonicity of the fluid. We have a countercurrent mechanism, and countercurrent basically just means going in two different directions in the nephron loops, in the descending and ascending loops, and this helps us to make sure we have a hypertonic solution, okay? And so that means we have a lot of solutes. And this mechanism is called the countercurrent multiplier, by where we actually increase the number of ions, and this is also assisted by the vasa recta. The countercurrent mechanism in the nephron creates that high ion concentrated fluid, the interstitial fluid, so that urine is concentrated by the collecting ducts when they're made more permeable to water, okay? And so the function of this is to concentrate urine. All right, so here we have the urine concentrating mechanism. When we have low antidiuretic hormone, okay, low antidiuretic hormone, the distal convoluted tubule and collecting duct are impermeable. So water is going to be excreted here as dilute urine. It cannot re-enter or be reabsorbed into the interstitial fluid. So on the right here in B, we have higher levels of antidiuretic hormone, and the distal convoluted tubule and the collecting duct will become more permeable, allowing water to be reabsorbed into the interstitial fluid, concentrating that fluid on the inside, and then so water will then leave as concentrated urine. And so that tells us we need to let go of water, and so this is going to be more full of ions and things that we need to get rid of. So here we're looking at the countercurrent multiplier. In A here, we have solute concentration of the interstitial fluid becoming hypertonic here. Okay, so it's going to get more hypertonic at the tip of the nephron loop due to the fact that the descending limb here is becoming more permeable to water, allowing water to enter the interstitial fluid. So we're allowing water to enter there. And so the fluid, as it moves down, is becoming more hypertonic or more concentrated. In B, we can see that as the solutes are reabsorbed from the ascending limb, and you can kind of see this in A, as they're being reabsorbed from the ascending limb here, this is going to cause more water to be lost. It's going to increase. So we start here with a little bit of water, and then we have a little more water, and then we have even more water because we're increasing the solutes as we move here. And so we're going to keep concentrating. So the countercurrent multiplier increases the solute concentration of the interstitial fluid progressively. It keeps getting more concentrated until it's almost 4 times more hypertonic than plasma. So the countercurrent mechanism in the vasa recta absorbs the water and maintains sodium chloride concentration, the gradient for the sodium chloride. Urea is a byproduct of amino acid catabolism in the liver. The amount eliminated really depends on the diet, and a product of metabolism of some nucleic acid bases like adenine or guanine is uric acid. About 10% of that is secreted or excreted, and about 80% of urea of water is reabsorbed from urea via the collecting duct. The composition of urine is a reflection of the amount of water in solutes that the kidneys need to eliminate in order to maintain homeostasis. It can vary from time to time due to dietary intake and, of course, physical activity, but it is composed of about 95% water, contains urea, uric acid, creatinine, may have trace amounts of amino acids and electrolytes, and, of course, volume varies greatly with fluid intake and some environmental factors. All right, so renal clearance is the rate at which a chemical is removed from the plasma. It indicates kidney efficiency. We have a few different types of tests. We've got inulin clearance, creatinine clearance, and then para-aminohippuric acid, or PAH test. And these help us to calculate our glomerular filtration rate. A decrease in glomerular capsule hydrostatic pressure is going to increase the rate of glomerular filtration. So tests of these tell us if there are if there is glomerular damage, or it can monitor the progression of a renal disease. An increase in glomerular osmotic pressure will decrease the rate of glomerular filtration. So inulin clearance, creatinine clearance, and that PAH test can indicate, it can measure kidney function and indicate renal failure. PAH can measure rate of plasma flow through the kidneys, and then we can use hematocrit to calculate the rate of flow, blood flow through the kidneys. So urine is going to be formed here in the nephron. It is going to pass to the collecting duct through openings of the renal papillae, and then it's going to enter the minor and the major calyx here, pass through the renal pelvis, through to the ureters, and onto the urinary bladder, and finally the urethra will carry the urine out of the body. Ureters are going to run parallel to the vertebral column. They are generally about 25 centimeters long and join the urinary bladder in the pelvic cavity. We have 3 different layers that form the wall of the ureter. That's going to be the inner mucosal coat, middle muscular, and outer fibrous coat. If you happen to have a kidney stone, which is also called a renal calculus, in a ureter, you're going to trigger the ureter-renal reflex, and that's going to cause strong wave-like peristaltic waves in the obstructed ureter. You're going to have reduced urine production in the affected kidney, and of course you're going to have some pain. All right, so the urinary bladder is a hollow muscular organ. It's located within the pelvic cavity, posterior to the pubic symphysis and inferior to the parietal peritoneum. We have a triangular area on the internal floor of the urinary bladder, and we call that the trigone. All right, and so it really does look like a little triangle. It has openings at each of the three corners, 2 for ureters and 1 for the urethra. We have muscle fibers that make up the detrusor muscle, and that is the muscle of the bladder wall. And then we also have an internal and external urethral sphincter. Here you can see many of these features here, the 4 layers. We've got the inner mucous coat, submucous, and muscular coat. You can see the submucous coat here. Then your inner mucous coat lies in here. You can see the detrusor muscle here. You can see the trigone or triangle shaped here with openings for the ureters and the urethra extending out of that. You can also see here is the urethral sphincter area and the internal sphincter area. So the urethra is the vessel that takes the urine. It's a tube that takes the urine from the bladder to the outside of the body. It's lined with a mucous membrane, and it does have some smooth muscle fibers long, but these are different for men and women. For female, it is only about 4 centimeters long, and this causes a problem for females because if you're not careful in how you wipe yourself or your child, if you have an infant or a very young child, if you do not wipe them from front to back, the fact that this is so short makes them much more prone to bladder infections if you are to perhaps get E. coli in there from feces by not wiping correctly. So this is very important to know and to be sure, especially if you are a male and you have a child, because a lot of times males aren't as familiar with this because as females we're generally are taught very young to wipe from front to back, because if you don't, you can get a really bad bladder infection. If the E. coli travels on up, you'll get a kidney infection as well, and those can be particularly nasty. So in a male, instead of 4 centimeters, it's almost 20 centimeters long. So it's much, much harder for bacteria to travel up that way, okay? It's got a dual function for both excretion of urine and semen for reproduction, and it has 3 sections here. You have the prostatic urethra, membranous urethra, and the penile urethra. Micturition is the scientific name for urination. Conscious control of micturition can inhibit the micturition reflex by using nerve centers in the brainstem and the cerebral cortex. Urine is going to leave the urinary bladder by micturition or the urination reflex. This can be controlled by the relaxation of the external urethral sphincter. We'll have distension of the bladder that's going to stimulate the urge to urinate. The detrusor muscle is going to contract along with the abdominal wall and pelvic floor, and so that will cause the external sphincter to relax. This chart here in your text goes over all the individual steps that occurs along with this. Here are just some different abnormalities of the urinary system that can occur developmentally. Things like the horseshoe kidney, where kidneys fuse at one pole, usually the lower or bottom portion, and most of each kidney on the opposing side there. Polycystic kidney disease, and that's where you get cysts in the renal tubules or the collecting ducts. And there's some others here as well. So over the scope of your life, the urinary system, often in structure and function, can hide or mask some of the age-related changes, but they do often become slower to remove nitrogenous waste, slower to remove those toxins, and be able to compensate and maintain homeostasis. So the kidney can appear more scarred and grainy. You will lose some of your kidney cells. By the age of 80, your kidneys have lost up to 33% of their mass. All right. Kidney shrinks because we are losing glomeruli. You may develop protein being excreted in your urine. The tubules can thicken and harden. Kidneys are less able to activate vitamin D. Your bladder is less able to hold urine and flow to the kidneys slow. So there's lots of changes here that occur. They just aren't as drastic as we see in some other systems.